All right. You guys will have to excuse me. About 2 hours ago, jet lag hit me like a ton of bricks. So if I'm saying stuff that doesn't make sense, please just raise your hand. Now we're going to talk about fixer-assisted femoral derotation over a nail, and we'll go a little bit more into the technical aspects of it. I like to do them proximal. It heals well, predictably, and it doesn't have as much impact on patellar tracking as distally. I'm not sure that distally induces that much patellar maltracking when done properly, but there's not a lot of data to conclude positively or negatively. We can correct both retroversion and anteversion using that method. There might be a benefit in doing it distally for retroversion when it comes to patellar tracking, but once again, it's mainly anecdotal and not a lot of data to back it up. First, before you correct anything, you have to assess it. Clinical examination should be your first line of assessment, and in my practice, I like to confirm with a CT scan. Once in a while, especially in neuromuscular problems, you'll find that soft tissue contractures give you a false impression of excessive anteversion or retroversion, and I don't recommend compensating a soft tissue problem with a bony correction, except in very specific circumstances. In most healthy individuals, you do not want to do that. This is on the left an example of a severely anteverted femur where the femoral neck and the femoral head looks extremely vertical when the distal condyles are pretty straight, versus a normal femur completely on the right with about 10 to 15 degrees of anteversion. How do we assess femoral version? Well, it's very simple. We use a prone physical examination. And every time a patient comes into my office, if they tell me, oh, I've seen so many people, they always say, nobody looked at my rotation. Nobody asked me to get on my belly, and no one looked at my hip rotation. So thank you, doctor. The way we do it is we put the patient prone. I either have a parent, if it's a child, stabilize the pelvis, or my assistant do it. And then I turn the legs outwards. If you turn the legs outwards, it's internal rotation of the hip, if the feet are pointing outwards, and vice versa, inwards for the external rotation. In most individuals, we should be about 50-50 or 45-45, the same amount in each direction. So if there's a big imbalance, as in this case where there's 90 degrees of internal rotation but barely anything of external rotation, you're facing femoral anteversion. In the other direction, if a patient has a lot of external rotation but barely any internal rotation, then you're facing retroversion. Now, a retroverted patient might be a very nice ballerina, but a very poor runner, but vice versa, right? Someone who's very internally rotated might not be as good a dancer, and that's something that you might want to address with your patients, especially those that are high-level dancers, gymnasts, soccer players. Not all deformities must be corrected. There has to be some clinical correlation of hip pain, knee pain associated with it, fatigue, and so forth. So the first step, I think one of the most life-saving steps that prevents fat embolism and sometimes intraoperative pulmonary embolism is the venting of the canal. So your first step, before you even find the entry point, before you put your half pins, is to drill the level of the osteotomy. I use a 4.8 millimeter sharp drill bit. The smaller the drill bit, if you're in a normal individual, the more you will burn the bone, right? So a 2.5 millimeter drill bit will work a lot more in a thick femur than a thick gauge drill bit. The other benefit is that it provides pre-positioned bone graft. So the swerve, the reamings, come out of the hole through the vent holes, and it grafts your lengthening side. Some people will do it through an intramedullary saw, but I prefer a Di Bastiani type technique. It works well, it's predictable. So how do we do it? First, we drill the multiple drill holes. See, nobody mentioned I was not in presenter mode. And then we find the entry point of the nail. In most children, you'll want to use a trochanteric or a lateral entry nail. However, in most adults, a piriformis entry point is wonderful because it creates no proximal femoral deformity in varus. We find the entry point. We over-ream either with an ACL reamer, but most sets nowadays have an entry reamer, and those are the ones that I like to use. Then we insert the guide wire. The guide wire pretty much goes wherever it wants to go, but you should try to center it as much as you can. Then it becomes the easiest nailing of your life because you're reaming a canal that is intact. I recommend reaming up to 2 millimeters above the nail size that you're going to use. And the way I choose my nail size is as soon as I have a reamer that has a lot of resistance or chatter in the canal, that's usually the nail size that I will use. So if I end up with a lot of chatter at, let's say, 10 millimeters, I'll use a 10 millimeter nail, and I'll ream up to 11.5 to 12 millimeters. Once the canal is reamed, that's when you will position your rotational markers. The first rotational marker is placed in the lesser trochanter. Dr. Herzenberg has a wonderful trick. If you're not sure if your rotational marker will be in the path of your nail, what you do is you put a reamer of the size of the chosen nail at that level in the patient's canal as you apply the cannulated technique Shank screw, and it makes sure that every time your Shank screw will be outside of the path of the nail. The distal pin will be placed perpendicular to the distal femur joint line, but distal to where the nail is predicted to end. So you have to measure it carefully first and put the nail distal to that. So this is what it looks like proximally once your pin is in the lesser trochanter. And if you put a reamer in the location of your reaming or the entry point, you'll make sure that the pin is never in the way. We use an intraoperative level with a little bubble in it. Now, very important fact, make sure that when you measure that your pin positioning, that there is no bump underneath the knee. You want to have a leg that's perfectly flat, because as soon as you start elevating the leg, then you're measuring your angle in a completely different plane than when the leg is straight. So you might either under or over correct your rotation. So the leg should be laying perfectly flat on the table. You can apply your external fixator, or you can decide to do it with just Steinmann pins like I mentioned earlier. The benefit of an external fixator is you prevent distraction of the osteotomy, and it makes sure that there's good control over the osteotomy. And then you pass your osteotomy through. I cut the posterior cortex first, then I go anterior. Why do I do that? Because the posterior cortex is under compression, the anterior cortex is under tension. Tension cortices tend to break clean, while the compression cortices tend to break with a wedge. If you end up with a wedge, you have to break it off. Otherwise, rotation will be extremely difficult to correct. So my recommendation, if you end up with a wedge through your osteotomy, no big deal. You can do a counter incision anteriorly and then just break it off from anterior to posterior. Once that's done, you correct your rotation, verify that the pins are collinear with your level. In some cases, you can't do that. In some cases, anatomically, you won't be able to put pins that are divergent to start with. My recommendation is put them collinear to start with and end them with the amount of divergence that you desire. Then all you have to do is put the guide rod back in. Now I do the osteotomy actually with the guide wire back in. It offers a little bit of extra stability as you break the bone. And all you have to do is insert the nail, lock it proximally, lock it distally. Be mindful that some of these screw holes have a wiggle room, have play in them, and it can be up to 5 degrees. So I recommend over-correcting 5 degrees. There are more and more nails that come out on the market with some polymer inside of the locking screw holes in which the locking screw bites, And those don't tend to rebound as much because you have a lot more resistance. You have a more intimate fit of the locking screws in the holes. So just know which implants you're working with, know their quirks, and if they don't have polymer in them, you need to overcorrect a little bit. And then it's just a rule of thumb. Some kick back, some do not. So in real life, in a real bone, we do the multiple drill holes. You can see actually there's a little indication down here that the vent holes were done. The entry point is found. The entry reamer is used to open the canal. The canal is reamed. And this is what I was telling you about. The reamer of the size of the nail that you're going to put is inserted to the appropriate depth at the lesser trochanter, and we use a cannulated technique to insert the first shank screw. So first we start with a wire, we drill over the wire, insert the pin, and you have to make sure that there's a nice space between the pin and your reamer. It doesn't have to be a big space, but as long as there is space, the nail will be able to go through. The last thing you want is to have a pin that is in the path of your nail and all of a sudden you're in trouble because the bone is broken, you've lost the rotation because you removed the pin, and now you're not in control anymore. The nail is inserted. I'm not sure what that is. And then the nail is locked proximally, distally, and rotation is maintained. I believe that Dr. Herzenberg has a tendency to put the reamings back into the patient afterwards as bone graft. I don't think there's anything bad doing it. I personally do not do it. I'm sorry, Sensei. And this is what it looks like at the end. So we have a very anatomic looking femur with the appropriate amount of correction. So the take-home message here is be in control, take your time, use an intraoperative level or a gyroscope, and you'll get good results almost every time. Thank you.